some of this will be redundant from Dr. Stern. But I'm a slow learner, so I need to hear things twice. So maybe some of it will stay the second time around as we whirl through things. I also want to recognize my co-authors on this talk. Jimmy Smith is our clinical orthopedic oncology postdoc. He helped pull some of the cases. Nick Toby is my fellow. He's taking a job at Penn State where he will be a resource for central Pennsylvania, whole state and beyond.
Making sure.
And then I also want to give a shout out to Danielle Brown, Danny Brown, as we affectionately call her. She's my orthopedic oncology partner. And we make up sort of the surgical oncology aspect of patients that take care of providers that take care of TGCT. You'll meet Janai Carr-Asher, who was actually first person I recruited when I took the chair job here in 2018. We brought her up from UCLA. And what she mostly does mirroring models of sarcoma. She's a molecular biologist extraordinaire, but she does do some of our clinical trials work, as you will hear from her. So our orthopedic department, just a shout out, we are really trying to be multidisciplinary, comprehensive. While the majority of us are orthopedic surgeons, we also have medical oncologists, for example, and other rheumatologists, and a bunch of people who are not necessarily orthopedic surgeons housed in our department. We really want to advance knowledge through innovation, education, and advocacy, and we're really honored to host the Learning Day today. This isn't a CME class, which is continuing medical education, but I always feel people need to know a little bit about my background. This is a busy slide because I'm an old dude. I've been working with industry and peer-reviewed funding sources for years. And so these influence everything I say. So please take everything I say, realizing that people have supported the mission in various ways. And so I may have some biases. We all do. I just want to raise awareness. But most importantly, I want to recognize my why. So this is the very first patient I lost to osteosarcoma. We're not here to talk about osteosarcoma, but I thought I would share this with you because the mom gave me this picture after she lost her daughter, Sky, to osteosarcoma. She had a pelvic sarcoma at a very young age. This is me as a young professor when the Police were still producing music, probably. This is when I was talking with her, realizing that she was probably not going to be here for very much longer. Mom took the picture, and when she passed and I went to the funeral, she sent me this picture after and said, please tell the story of Sky. So Sky is my why. When I have a rough day, I just think about the journey that this family went through. Everything is relative. Fortunately for us in this room, TGCT is not, in most cases, a lethal condition. But my motivation to push the field and to take care of patients is because I appreciate the impact it has on individuals and families. So here's the Sky. So this is the overview of our talk. Some of it has already been presented actually through Sydney's outstanding presentation, but this is what we're going to go through over this 45 minutes. She did edit out, expurgate a few of the more graphic surgical pictures. I left a few in for awareness, but I will try to remember to say close your eyes if you're squeamish. But if I don't, I apologize. They're not too bad, I don't think. But the reason I've included some of them is because some of the families actually do want to see what this is about. So that's the warning. This is an opening vignette. This is the straightforward case. It's a 47-year-old man with a 1-year history of a knee mass. This is a magnetic resonance imaging scan, the MRI, which has really changed things. It was just coming online when I was entering practice. It was a technology that has really advantaged TGCT patients and solid tumor patients in general. Before that, it was just plain radiographs, CT scans, and physical exam, but we can get so much more anatomic detail. And what we're seeing here are side views, what we call a lateral view of the distal femur or knee joint area. And then this is an axial view. What an axial view is like if you imagine a loaf of bread and you slice it, and then you take the slice and you look at it. That's what you're seeing here on FOSS. It's the MRI of the, or excuse me, the image of the femur bone. This is the patella or kneecap. So here you're seeing it in profile from the side. So just like my big nose, there's this big mass right here on the side. And then here is as if you took a slice right through my scalp, and you're seeing my nose right here with this big mass. Okay. And that mass has very much the characteristics of tenosynovial giant cell tumor. General synovitis or inflammation of the joint will look very general or diffuse. So when you see something really nodular or localized like that, 9 out of 10 times it's going to be TGCT. And especially if you see little dark spots in it, which you don't really see as much, but you do see what we call loss of signal, which reflects something called heme sitter, and we'll talk about that a little bit more. Don't get overwhelmed with the medical terminology. But the point here is, I think almost every radiologist will say this is most consistent with localized or nodular TGCT. Doesn't necessarily mean biopsy. If symptomatic, take it out. If not symptomatic, don't take it out. So for example, if I'm running around and I sprain my knee and I go and I get an MRI and I see a doctor in my knee, by the time I see the doctor, it's hard to get into the doctors, right? It's feeling fine, and we get this MRI, and we would probably say, we can watch this. It doesn't have to come out. We don't have any suspicion for being a cancer. We don't have any suspicion for being necessarily aggressive. So we can watch it, and we actually have a case of a TGCT, nodular TGCT that resolved, that I'll show you a little bit later. But in any case, this is where it is, and there's that cursor. It's not a squiggly line, it's actually a nice round line because it is relatively geographic. So you've already seen this slide, but just to hit the salient points, it's not cancer, yet it is like a desmoid. People know desmoid tumor. Desmoid tumor is very, for us sarcomatologists, desmoids and TGC are very similar. They're local problems, but then patients usually don't have life-threatening situations around them, thank goodness. But locally, they can behave as badly as a malignancy. So when I talk about desmoid, my sobriquet or title for most of my talks is the malignant non-malignancy, with the emphasis that it's not malignant, but it does malign a patient. It does cause real problems, and from a local standpoint, can be really devastating. And the same can be true of TGCT. Fortunately, most of it is nodular. Fortunately, most of it is surgically curable. But as unfortunately, probably some of the people in this room can attest to, it can really alter and malign your life. So we want to recognize that. And in fact, there are some cancers that from a local control standpoint are very easy to treat. You know, basal cell carcinoma from sun exposure and aging, shave that thing off and you don't have anything to worry about. You may have a little blemish for the rest of your life, but it's a cancer. But I think most people would say I'd rather have a basal cell shaved off my cheek than I would have diffuse tenosynovial giant cell tumor. So just for perspective. And we've heard of, we'll get into the definitions again, just briefly. But as Sydney has already pointed out, in 2013, the World Health Organization came together around the nomenclature or the way we call these things, because there was all these, I gotta get your slide, down my side, that one, your side, how they come now all into the TGCT category. And this was great because we all wrote letters to the World Health Organization around this back in that, just before that, to really push for this because patients were so confused. The other thing that's important now, though, just to highlight, which we haven't discussed yet, is tenosynovial giant cell tumor must not be confused with giant cell tumor of bone. The names are confusing because TGCT can erode bone, and people say, well, is this, you know, if someone isn't really familiar, it's like, is this a giant cell tumor of bone? Because we treat that differently than we treat TGCT. So it is important for the layperson to realize that giant cell tumor of bone is distinctly different than tenosynovial giant cell tumor. They both have giant cell tumors. They have different pathways, or they both have giant cells within them, I should say. They have different pathways of pathogenesis, which means how they form. But if you, when you are advocating for this and you're hearing about talking with new patients and families that have this diagnosis, make sure that they understand the difference between TGCT and giant cell tumor bone, which sometimes is abbreviated GCTB, which can be really painful. So next conversation with the WHO. Very common scenarios where it'll present, as we heard, in small joints. This is an MRI, again, an axial image. So the hand sliced like a loaf of bread, and you're looking at the digit, and the other 3 digits are normal, but you can see this area here with this nodularity around the tendon sheet. This is the tendon, these things here, and the tendon glides. It has a little tube of synovium that allows it lubricates the tendon, so it allows it to track smoothly, and if it hypertrophies, and it can present as swelling. The good news is it is pretty distinct. The bad news is because it's in such a tight little spot when it's in the hand, the local control rate, which means when we surgically go in and remove it, is not as good in the hand as it is in the knee. So if you've got that same mass in a big old joint where you can go in either with a scope or open, and we'll have some pictures of this, and take it out, 95% cure rate. But when we have it in the hand, we tell patients that even with a very well executed operation, we have to surveil these patients because they can recur. And that's just because of the anatomic considerations, because you have these very fine structures called the digital nerve and the digital artery, which are the diameter of a hair that you want to preserve because it's a benign condition. You know, for the sake of comparison, if this was epithelial sarcoma of the hand, which is a relatively common sarcoma of the hand, the only way we would get a negative margin on this would be to do an amputation, and we would do it because losing a finger is better than losing your life. But when we're talking about TGCT, we're talking about quality of life, and losing your finger sucks. And so I take the small chance of coming back in my hand, even as a surgeon, than I would at losing my finger, just because we still win the battle in more than half the cases. But when it is in the hand or in a small digit or a small joint, the risk of local recurrence from nodular is high. So that's a take home. We've heard a little bit about this. Again, it tends to be a young person's disease, and we do think, but the databases will help inform this moving forward because we're collecting more and more information. As we enter the senescent phase of life, which is what I'm going through now, where I'm never as good today as I was yesterday. It always seems, we're sort of slowly going this way. That many of these diseases or symptoms become less intense as they get older. We think that may be hormone related. There's telomeric, which means the biologic clock effects. But many of these conditions over time, as we get into older age, tend to become a little bit more symptomatic. But the downside is obviously in our most vital years, we want to be most active. That's when it's most active. Anything to comment on that? Yeah. So, and it can be any place. So the Englishmen in London, New York, Bangkok, wherever, they're still Englishmen. Still sting. Can't believe I still want to such an old person. Okay, so this is, you can get multifocal synovial giant cell tumor. It is very rare. And we don't think these are metastases. So cancer by definition is something that can spread through a biologic process, which we're not going to get into today, but it's a very active process where it crosses something called a basement membrane or a barrier, and finds an ability to set up shop in a new location, usually with a different type of what we call tumor microenvironment. So in osteosarcoma, Sky, she died from lung metastasis. The lung microenvironment is very different than the primary osteosarcoma environment of the bone. And the cancer can set up shop in a new spot and has taken on new features that allow a bone cancer cell to live in the lung. And that's what makes cancer so scary. And the reason it's, just as a quick sidebar, why it's called cancer, named after the astrological sign, is because, and the crab, is because Socrates noticed that a sand crab would show up in one area on the beach, and then he would see it pop up somewhere else. And he was the one who sort of said, this is like this condition that they treated in ancient Greece, where they would notice a mass would show up somewhere else, and then obviously with very technologically crude medicine would see it somewhere else. And that's how it got the name of cancer, that's cancer can show up anywhere else, someplace else. So what I'm getting back to TGCT, the latest thinking here is that this is multifocal TGCT, but it's not TGCT in this case from the thigh area going down to the ankle or the hip. It's something in this patient's somatic genetic blueprint that predisposes them to multifocal disease. Anything you want to comment on that?
So it's like lightning striking twice, right?
Right.
The odds are incredibly young.
Right, but we don't, it's not, it's important that we don't think that it's spreading. It's just, yeah, two separate events. That very rare. And unfortunately for the diffuse type, this is a very typical presentation that we as orthopedic oncologists will see. I think everyone in the room can appreciate the relatively normal knee or the normal knee to this really swollen situation, which can be an absolute nightmare for people. I mean, that is just, it's just an inflamed, painful joint. And hopefully no one in this room has this advanced disease, but this is a real problem. And over the course of my 30 years of practice, I have done some what we might call palliative amputations for some patients well before we had any of the latest therapies, which we're going to talk about. But I can recall several patients that I have treated over the course where we've done multiple surgery because of this kind of tumor burden. And ultimately they got so exasperated, they said, look, just take my leg off because I can't go through this thing. And we really hesitate to do that. And we certainly rarely do that now with some of the CSF1R inhibitors that we'll be talking about a little bit later, but for historical context. And please, at any time, interrupt. Yeah.
I was just gonna ask, so is that, I'm not sure if it matters or not, localized or diffused? And I think of mine's my ankle and I have a lump. That like, is the swelling and all that related to one tumor? Like, how does it get like that?
Great question. And then also, just so you know, I was a rock climber. That's the skiing affinity. And what I lacked in talent, I made up in decibels that was loud so people could tell how bad I was. So I lost my hearing. I have a cochlear implant, so I heard you just fine, but you project very well. So I just, if you ask a question, please project. So this is diffuse. And usually a nodular, and we'll get into this, a nodular usually will not present with that kind of swelling. So how it forms, pathophysiology, again, I won't do it justice compared to what Sydney did, but we'll go through some of the salient points. Yeah, I love it. Yeah. So you've seen this slide before already. For the localized disease, you tend to see it in smaller joints. So we'll see it in the hands, we'll see it in the feet, we'll see it in the ankle. We certainly see it in the knee too, but the most common sites are the smaller digits. There's less synovium. The mutation is potentially affects fewer cells, and so you don't get the fronds everywhere. As compared to the diffuse type, where you see it much more common about the knee, but you can see it in the ankle, the hip, and the shoulder. So again, you've heard this already, and you've seen this slide before. I love translocation biology. Translocation meaning cutting and snipping, in this case, genetic material from one chromosome or book to another. I use the metaphor of book and book chapters because we have actually, in my mind at least, we have the book in every cell, but there's only certain chapters that you can read. So if you take the book, it's everywhere, but certain chapters are censored and you can't read them, and certain cells will have only certain chapters that allow them then to be cartilage or heart tissue or what have you. But we all have the same book in all of our cells. And so the translocation biology is really fascinating. I spent the first 15, 20 years of my career looking at translocation biology in synovial sarcoma and Ewing sarcoma. Many of the cancers that we treat, sarcomas, have the same event where you have cutting and snipping. And when I try to train or talk to the ortho residents about this, they eyes glaze over with molecular biology because they want to do the real cutting and snipping. But I always talk about the molecular scalpel, that these are molecular events, but it's like cutting and stitching and surgery, that you're cutting off a piece of DNA and sewing it onto another end. And I love Steve mentioned that. So yes, you get this hyper expression of CSF1 from the minority of cells here that then cause the synovial tissue, the macrophages, to just get hyperproliferative. And this is just a cartoon to sort of show how it would look if this was a real surgical case, and we took one out that actually was a real surgical case that looked like this. This is sort of warming you up for some, not nearly so graphic, but some graphic pictures coming up. This is what it sort of looks like. You open it up and it's just this sort of brownish, yellow, frondy material in the diffuse variants. And I'll have some pictures of the nodule as well. The initial symptoms in the diffuse type are pain and swelling, stiffness. Sometimes patients will feel unstable. Initially it's episodic, but then becomes more and more progressive, usually to the point where they see someone and it can be a really, really debilitating situation. This is with an arthroscope. So the two different types, when you stick in a scope, and people know what an arthroscope is, right? It's a little device to look into the knee or the hip or wherever. And this would be a nodular variant. Sort of looks like one of those clown balloons. It's a little twisted. Usually it's spherical and you can really just pluck it out, but sometimes it has this little longitudinal component to it. Compared to this, if anyone's a scuba diver, this reminds me of night scuba diving. You just see this frondy material, you're sticking in the scope and you see it waving back and forth, and we will literally go in and shave the stuff down. But the issue is, as I explained to patients, when we do that, it's nice because it's minimally invasive, but I didn't shave this morning and I've got a little bit of a shadow. I can shave this evening and I'll have a shadow tomorrow. It's the same thing when we do these synovectomies, when we go in and scope it, get rid of the problem temporarily, but it comes right back. And we'll talk a little bit as I go through this about sort of the combined approach of scopes and open surgery. For localized, it's usually much less symptomatic. It's usually, I feel this little mass right here, or I've got a little click. You go see your primary care doc, they first tell you it's in your head, and then you finally tell your primary care doc, no, this is real, and they finally get an MRI, and then they finally get the read, and you're in the pathway of getting this taken care of. But this is a nodular variant right underneath the kneecap. Again, this is the knee profile, so you're looking at it from the sides of the thigh bone called the femur, the shin bone called the tibia, and this is it. This is it out removed. We'll talk a little bit more about the surgery again throughout this talk, but whether or not to take out with a scope for the nodular versus the open is really where it's located. Sometimes it's really right there and you can feel it. To do this big process where you have to inflate the knee with fluid and do all these things, and then go in there and try and shave it out and you're sort of grinding it up versus making a small incision and just popping it out. Call me a minimalist, but I tell folks that usually if it's right there, we can get it with a small incision. Let's just take it out as opposed to swelling up your whole knee. So if you do have nodular disease, that's a question you want to ask your surgeon. Do you think it's best to get it out with a scope, or do you think it's best to get it open? And sometimes the open is a quicker recovery, albeit the incisions are a little bit longer. But what's interesting, and the data through TGCT support and other investigators around the globe have shown that it takes 3 to 4 years on average to get the diagnosis from that moment you have where you say, gosh, something feels weird, to the time where you get to sit with a TGCT specialist who really knows what they're talking about takes about 3 to 4 years. It's remarkable. It's because it's sort of like insidious. Common things happen commonly, and in defense of modern medicine, with all of its medical problems, if we were ordering an MRI on every single person who had an ache or pain, the people with real problems wouldn't be able to get MRIs just because there's just such demand. So there has to be some discretion in ordering tests, and common things do happen commonly. We all get episodic back pain. I've had knee pain, a variety of other things. So I'm not making defense of anything. I just putting it into perspective, hopefully. But you can see this is just an enhanced image of an MRI to show you the different ways it present. This again is a nodular variant, but it's in the back of the knee. Again, you're looking at the knee in profile, the front of the knee and the kneecap are right here. Back here, there's a bunch of critical structures, the arteries, nerves that go down to the foot are there, and it's much trickier. And this is a real tricky problem that we'll show some cases of in a little bit. And then these are just variants of diffuse. And this is involving the knee joint proper here. And then this part back here is much more challenging to manage. And this is a case where it's all in the back, nothing in the front. And this is a real challenge for patients and surgeons to manage. I'll talk about this. I can get you the reference. I apologize, it's not on this slide, but this is a really nice summary of 500 patients that were followed along. So they have the symptoms that we've already talked about, but it's actually 497. We're just going to call it 500. Initially, about 60% are seen by sports medicine doctors. Appropriately, you'll see your primary care doc and they'll say, oh, that sounds like you may have a meniscal injury or a cartilage tear or something like that. Sports guys, a minority, less than 1 in 4, are actually get in to see an orthopedic oncologist, and some will be seen by rheumatologists or other sorts of providers. So those are the gateways into the journey of PVNS, TGCT. Once they have the diagnosis, then referrals, about 75% are getting orthopedic oncologists. I'm biased in my statement here, but I do think because we see the full spectrum, orthopedic oncologists probably are the best gatekeepers for the journey of a patient with presumptive or thought to be giant cell tumor, tenosynovial giant cell tumor, because we have an understanding of the medical therapy, albeit that we don't administer. We understand the intimate journey, the nuance and intimate aspects of the journey of patients with TGCT. So we generally do prefer that initial contact point into a multidisciplinary team is an orthopedic oncologist, but that, Janai Karasher, if you're going to meet, is amazing too. And so sometimes medical oncologists are the portal, but because they don't have the functional training that the orthopedic surgeon does, my bias is that the orthopedic oncologist should be sort of the gatekeeper there. But that's open for discussion. About 60% are treated by, 75% are by orthopedic surgeons in general, and 60% are by orthopedic oncologists, and almost a little over 1 in 4 by medical oncologists. And we're going to go through this a little bit. This is a very busy slide, but there's all of these things to consider as we get educated on TGCT. What's important to point out, of these almost 500 patients in this study, 393 patients were treated with surgery, and almost 2/3 of them had local recurrence. So again, for all comers, it really can be a problem. So we do usually start the workup for patients with TGCT with a good old-fashioned plain radiograph. This is someone who had elbow pain, and what you can see on this X-ray picture is there is increased soft tissue density here. So just looking at this radiograph, I would know that this patient has a complaint of anterior elbow swelling or pain and inability to bend their elbow. And what you notice here also on the radiograph is the erosion of the bone. And that normally this white line of the cortex comes straight down, but this is an indentation. And it does, if you look at it, it does look like it's literally being pushed in. The cortex, the wall is effectively maintained here. So when we look at that X-ray picture, we know that the patient has something in the front of their elbow. We also know that it's been there a long time. because things like cancers will rip right through the bone. So if, say, for the sake of just comparison in your mind's eye, they had a cancer in the elbow and it was eroding the bone, this whole bone, this wall wouldn't just be thinned out and pushed in, it would be gone. Because the cancer would have ripped through the bone. So when we look at this X-ray picture, the provider will know, the orthopedic oncologist will know. Pain in the elbow on the front, swelling, they're probably having difficulty bending their elbow, and it's been there a long time. But that's just scratching the surface. This is the front view of the elbow, and you can just see the density here is less. This is what the density should look like, and so this is darker. And that just means, again, that bone is being pushed in there. So a radiograph is important. We want to limit radiation exposure. Radiation doses are super small with X-ray pictures, conventional X-ray pictures, but we do think it is important, especially for patients with diffuse disease, because as that journey continues forward, there may be secondary changes to the bone that are arthritic in nature, and you want to know where they came from. So if you are a patient with a TGCT that's being treated and you haven't had a radiograph, we do recommend getting a baseline radiograph at some point, even if you don't, even on the MRI, it doesn't show any erosive changes. The X-ray picture really can step back and give us a big view of what the health of the joint is. So we do recommend getting a simple 2-view X-ray picture of the joint involved. Ultrasound, especially in the era of value healthcare, where we're trying to drive down these ridiculous costs of healthcare. Ultrasound is a very good way to surveil patients and to look at disease. So if, for example, if you're not on a clinical trial and you have disease that isn't too bad, one easy way to go is to get an ultrasound to surveil the patient. It allows us to quantify the extent of the disease. It's easy to go to for those of you who have been pregnant, had an ultrasound of your fetus. You know, it's really quite easy. It's a very benign process. The warm gel feels kind of comforting. They swab you in the area. It's much less of an unpleasant experience than getting rolled into a tube and hearing all that thunking and clunking and everything. So ultrasound is helpful in surveilling patients with TGCT. And then when you notice growth, then getting an MRI. So that's sort of a value-based proposition. Yeah, please.
Does this depend on the location of it? So it's deep, say, by a popular region of it, are you gonna be able to see it with ultrasound?
Well, yeah. And so we're here at UC Davis actually putting together some trials and looking at surveilling sarcoma patients with ultrasound. Because we get so many scans. Now, if you're getting worsening symptoms, this is a whole discussion of a patient's having worsening symptoms, or there are really concerning features on the prior TGCT MRI, certainly get another MRI. But if you're just, I'm feeling pretty good, my mass hasn't really changed, it's getting ultrasounds to follow patients along, and then periodically getting an MRI is a value proposition, one for the patient experience being improved, and two, for driving down the cost of the healthcare. But the MRI really is the gold standard. It's the preferred method of imaging when you really need anatomic detail. This is a lateral or a sagittal view of the ankle joint. It's very dark, and I apologize for that. But this is the tibia bone, and this ankle, and you can see a mass right here with the arrow. And that's a nodular TGCT of the back of the ankle. And we would also be able to get those axial views, coronal views, which is like looking at it in the front. So generally with MRI, there's 3 views, 3 planes that we look at. Axial, like so it's slicing like a loaf of bread. Sagittal, which is like profile of the joint, and then coronal, which is looking straight on FOSS. And so here's a case of a popliteal or back of the knee tenosynovial giant cell tumor that on surveillance initially in 2021 measured 16.9. It was something that was picked up somewhat serendipitously. They sprained their knee and they got the MRI and they noticed this, wasn't bothering them. We didn't have any suspicions for anything bad. So we said, this is easily something that you can watch. To go in there and take it out either with a scope or open is a big deal. And there are some risks to it. So we followed this patient along for 3 years and it grew a little bit. But it's, and it looks smaller just because the size of the image is different, but it did measure a little bit bigger, so it grew a centimeter, but it wasn't bothering them, so we're still watching that patient because it's causing no problems, it's doing no harm, and there's a small risk of taking it out. If it starts to grow really fast, then we'll change the treatment. But here, you know, again, if we realize that this is someone who's 56, that person is starting to get to the point where there's what we call, again, senescent, getting older, then it may just plateau out. So there's no harm in leaving it behind. This is a less common, but something that I see more frequently just because of the nature of my practice. This is diffuse TGCT on MRI. This is again that profile view, the sagittal view. And what you see is just disease everywhere back here. This patient had a hard time flexing their knee. They had a little bit of questionable involvement in the front of the knee. Their main complaint was this fogginess in the back of the knee. Taking this out is very morbid. It requires an open approach because there's critical structure. So the patient lies on their stomach, and they have a surgery where we go in and we move the blood vessels out of the way and move the arteries out of the way, and literally have to piecemeal this thing out. So again, it's like a shower and a shave. We can make it all look relatively clean and pretty at that point after surgery, but the chance of coming back is very high. And now they have a scar in the back of their knee. They have a scar around their blood vessels, scar around their nerves. The scarring around the nerve can cause its own set of problems. So, and then when you have to go back in, or if the decision is made to go back in, now you're going through all of that scar, which is stuck onto the structures. I use the analogy of scar is like chewing gum in hair. If you've ever had that miserable experience, getting the chewing gum without damaging the hair is impossible. Luckily, it's easy just to clip off your hair, but you can't do that with arteries and nerves. So you're going in there. So you can't go into the back of the knee multiple times. So as orthopedic oncologists who grew up in the pre-CSF inhibition era, thank goodness for some other options. In terms of when to get a biopsy, again, if it's nodular and has certain characteristics on the MRI features, we don't feel it's necessary. If there's a clinical trial, certainly we need to get tissue because it's sort of the gold standard when we take a little piece of it and look underneath a microscope. And usually if we're going to treat with systemic therapy, we do like to have a diagnosis because, as we'll hear, there's some downsides to the systemic therapy. And so we want to make sure that this isn't something else. But that's a discussion to have with your provider because it's not always mandatory. So finding aspiration is when they just stick a needle into it. There's what we call a false negative there. They go in and take a piece of tissue, but it's just not enough to establish a diagnosis. So we generally prefer something that's a little bit, takes a core of tissue. So there are core needle biopsies where you can still do it with image guidance. Where this is a CT scan of the knee, and this is the biopsy needle going in, and you take a core so you can actually look at the architecture. It's a little bit more invasive. Sometimes we'll do open biopsies, or sometimes we'll do it with this arthroscope. And this is what it looks like. We've seen the picture of what it looks like macroscopically, meaning to the naked eye. Microscopically, in the nodular variant, it is a nodule, right? You can see it here. It's a swirl of tissue. This dark stuff is the hemosiderin. Hemosiderin is an iron-like material that you see in red blood cells and all of these deposits in TGCT that is very dark on the MRI and very dark on histology. It's one of the characteristic features of TGCT. But you have this, what to a pathologist or an orthopedic oncologist, you can look at this and you can say, this is definitely benign. It's not cancer. Doesn't have some of the cellular features of what cancer looks like. This is the pictures of the diffuse type with and without some immunohistochemistry. And because it's not a discrete mass, it's frondular in nature, it doesn't look like a lobule, it looks like sheets of cells, and what you can see are these giant cells right here. These are just infiltrative inflammatory cells, but right here, you can see these giant cells. See them down here. It's coalescing of these multinucleated giant cells from what we heard from Sydney, the monocyte lineage, which is stimulated by the CSF1. It's a lot of medical jargon I'm throwing at you, but hopefully you get some of the ideas here. So take a pause, see if there are any questions, then we'll sort of get more into treatment. Yeah.
MRI complication. Well, we hear that's gold standard. And that'd be difficult, especially for situation.
Yeah, so it's a good question. Fortunately, the question was, if someone has a problem with an MRI contraindication for some reason, what's the next best modality? If it's claustrophobia, there are open MRIs. That's the most common reason doctor can't stand it. One, when you try to talk them through it, you can't with sedation. They actually are much more sensitive radiologists now than for I'm doing any of you say. You guys are all maybe I don't even know who any is. But the idea is that they can allay a lot of the anxiety around getting an MRI, so that's against the point. But if there is a reason like you have most orthopedic implants, just so we're clear, are not contraindications to MRI. But if you have metal in your brain or metal in your eye, then those are really the two areas. The metal in the heart usually is okay. The reason is a magnetic resonance imaging is a magnet, and it spins around you. That's what makes that noise, and it aligns what we call your protons in the body. And metal obviously is magnetized. It's affected by that. So a very small population of patients can't get an MRI. When they can't, usually what we do is get a CT scan with contrast, IV contrast. Usually look at the joint. They also put in ultrasound to give us some of the relatively anatomic detail around the best of that.
You want water, you want water, I'll bring water. There have been patients that have possibly both, like have lung ability and have also like active using the and then it may happen in the possibility.
Yeah, there can be multiple sites. It's super there. I don't know the answer to that. I think my X out.
The registry was published this year. The registry data was published this year.
This year. So that was the registry.
Yes.
There you go.
Yeah, if you read that paper, you'll see that medical oncologists are just underutilized overall. So Taxi was around and underutilized, and though hopefully maybe a shift.
Other questions?
It's sort of a tangential question. I'm one of those special people that the MRI makes my muscles spasm. And it can be quite, is there any, do you help with that situation?
So I've not heard that before, so I have to do some research to find out, but so what I'm thinking is it that the muscles themselves are somehow influenced by the magnetic field, or is it understandably that there's some anxiety and that therefore you get some secondary muscle?
Yeah, it's definitely the MRI itself, because they, it sticks to the whole body. And it's literally just like from knee to hip. It all ceases up.
Note to self, we need a radiologist for the next Sky, so I don't know.
The radiologist didn't either, so I just thought I'd ask.
Yeah, so the question is, you'll have had giant subs with the bone, took care of it, you notice some burn soft tissue. We have all the details that giant subs with bone can grow in soft tissue, so that's probably what that.
So Englishman.
Okay. All right, so we're gonna talk a little bit about treatment, the balanced approach. It requires a lot of listening. We're talking about quality of life, we're not talking about absolute life. When we have discussions around sarcoma, obviously, huge amounts of empathy and sympathy. But it's like the center of the conversation is we need to grasp the fact that this has to come out when you have a sarcoma. We can talk about different ways that we're gonna think it out, but surgery is really not an option unless one wants to go get some medical advice, which is understandable. But here, surgery is okay. And there's upsides and downsides to surgery. There's upsides and downsides to medical therapy. There's upsides and downsides to some of the other things like radiation, which we're going to touch upon. So we need to do a lot of listening. It requires a team of providers. And if you are a TGCT patient, the most salient question you can ask your provider that's seeing you is, do you have a multidisciplinary, multiple disciplines tumor board where my case would be discussed? Because even though you're seeing potentially a real reputable orthopedic oncologist, for example, is that orthopedic oncologist checking in to make sure the diagnosis is right with the pathologist who really knows what we're talking about? Do they work with a medical oncologist who knows the non-operative management? Do they have a sarcoma radiation therapist who understands in the very few cases, and I have real hesitancy of radiation, but I want to that we have the whole team of people there to help with that patient or family journey. So it really is important to have a group of people. And again, this is sort of the cadre. Orthopedic oncologists, again, you've heard my opinion that we should really be the gatekeepers. We do a lot of the open surgery. I do some arthroscopy as well. I don't do it full time. So there are cases that I will, particularly tricky cases, where I will send to my sports colleague. I've recruited a specific surgeon, and I'll just give him a shout out. His name is Dr. Ryan Freshman. Yes, freshman, like the year before sophomore, who I brought in and has a particular interest in TGCT because we have so many patients who come in. But you really do want to have a really adept arthroscopist, because orthopedic oncologists, we just don't volumetrically, so to speak, do enough of it for the tricky cases. So you want to have a sports physician around, sports surgeon, radiologist, pathologist, and medical oncologist, as well as social work. A lot of patients understandably are stressed out about this, and we want to be able to support them in their journey. Despite the incredible work of TGC support nationally, you want to have some local support too. Waiting and watching is active surveillance. It is treatment. Okay. I say this for Desmoid too. You're not being neglected if your team says, you know what, we're hearing you. Doesn't sound like it's that much of a problem to you. Why don't we just check you back in 3 to 6 months? You can say, what, I really do want it out, so you can push back on that. But hopefully someone with experience will be talking to you to say, you know, the morbidity of taking this out when it's really not bothering you is okay. And while I've never had TGCT, if this was my case, I would not want someone touching me, and I would not want to take that medication for the situation that I'm experiencing. So that's not your doctor. Don't treat that as your doctor saying, we don't care about your problem. Instead, best thing for you is to actively surveil. Okay. And we get regular checkups. Again, I'm a growing fan of using ultrasound for surveillance, and then getting MRIs at a less frequent schedule. But observation is an acceptable way to treat a large number of TGCTs. And we actually published a paper with the Europeans recently showing that 2/3 of patients with diffuse type TGCT over several years had no progression of symptoms for people that were just, yeah, I don't like the fact that my knee is swollen. I've already had it removed once. But if you go in there again, it's gonna bother me, and it's not bothering me enough that I wanna have medication. And those patients, 2/3 of them actually, a couple of years later, were doing okay. So surveillance, if the patient chooses it, is a very reasonable thing to do. And we'll talk a little bit about our secondary arthritis. So here is a case that again showing our age. This is someone way back in 2010 got a MRI because they noticed a little bit of fullness in the back of their ankle. This is the ankle from the side view, the sagittal view. So this is the shin bone and the heel bone right here. And they had a little bit of mass. Nothing was done. And they came back because they had injured their ankle, and the mass is actually a little bit smaller. It's not completely gone, but over 13 years, it hadn't been a problem. So it can involute. Radiation, we want to be complete in our education. I am personally very opposed to the use of radiation in patients with giant cell tumor, but I can't say that it's wrong. There's evidence that it will shrink. There's a type called external beam that is the most convenient for a patient to experience. There are intra-articular, meaning radiation isotopes to be injected to. I just think that the amount of radiation to deliver to shrink that tumor causes its own set of problems. You get fibrosis or stiffening of the joint. You have secondary cancer risk down the road. So you're taking a non-cancer condition, treating with something that has a small chance. I don't want to be hyperbolic here, a small chance of causing cancer down the road. And there are other things on the table, especially now with CSF1. I really encourage people, if you're a patient or a family that it is being recommended to have radiation, I would get another opinion. I'm not again saying that radiation is wrong, but it's just something to me that you are bringing in another level of therapy that causes so many problems. You're sort of potentially making the treatment worse than the problem. This is what radiation looks like. I've already given you my opinion. The targeted therapy, we've heard already briefly about CSF1. We'll talk a little bit more about it, and then you'll get it from an expert in Dr. Carr-Astor's talk. Medical therapy in general. Before CSF1, we were using things like other non-specific tyrosine kinase inhibitors like Gleevec. There was steroid injections and a variety of other things. But those have really fallen by the way now that we have CSF1 inhibition. So saying what I said about radiation, I also want to point out that in certain very exceptional cases for an uncommon condition, such as spinal involvement, where we really only have one shot at surgery and we know they're going to go back, radiation may be necessary. The spinal cord can only take so much surgery, it can only take so much radiation, so you don't like to have it be recurrent. So in cases of the spine, which is super rare, we often will recommend radiation therapy. But even then, now, because I haven't seen one in the last few years, even now I would take pause and probably call some of my colleagues around the country and get their opinion about the case and talk about using a CSF1R inhibitor as opposed to radiation. But this is probably the one place where I might consider it just because of the trickiness of it. And then we'll talk about Pexi and the Selpnib as well as other agents. But again, this is just a nice cartoon to sort of highlight what Dr. Stern already has discussed. It's really the CSF1R pathway, the cells that secrete it that then prevent all of the downstream effects that manifest as TGCT. And Trollio, we want to have a very balanced discussion around this. So Bill Tapp, you probably know Bill Tapp, he's the head medical oncologist for the sarcoma section of Memorial Sloan Kettering. He's a very dear friend of mine. You know, we don't, Trollio has changed the life of so many patients. It's been a great agent, and it's still great there. We have patients on it, and we really believe that they are advantaged by it, and we want to keep them on it. Romvimza, which is always a tongue twister, is vimseltinib, which is also nice. It took me like 20 times looking in the mirror and vimseltinib. So it could sound like I know what I was talking about. This is a new agent that has a little bit less of an adverse event profile and is available. I have consulted for both groups, so I have some conflict there. So everything I'm saying here, I want to be very careful of. I've had financial relationships on both drugs. And I want to get that out there. I think they're both terrific agents. Okay. So let's do some cases. A 34-year-old woman, F means female, with initially presented at what we call outside hospital or OSH with diffuse TGCT, and she underwent arthroscopic debridement with an excision of a mass. So here's the disease. It's in the back. She has it in the front. It's very reasonable to try to do this arthroscopically, particularly for the front, but even with the really great sports surgeons, this is really tough to control with an arthroscope. Getting back there, even though they can do these slick little portals to get in there, it's almost guaranteed to recur if you take it out with an arthroscope. It's almost guaranteed to recur if you take it out open. So this is, again, how it was initially decided to be treated with arthroscopic debridement, which means clean out and excision. Unfortunately, within 6 months, she's still symptomatic, an MRI, and you can see the disease is back, like it was never gone, but they did have a post-op MRI that showed it was 95% removed, but it's back. And this patient was indicated. So a very typical scenario. Another scenario, 41-year-old male with a 2-year history of knee swelling and pain. Imaging very consistent with TGCT, which you see, you can look at this and there's really nothing else this could be, just these really dark spots or that hemosiderin that we've already talked about. I think any radiologist would say this is definitely TGCT. It doesn't necessarily need a biopsy to establish that diagnosis. Because of the extensive disease in the current era, this patient started on medical therapy because even in a very well executed surgical operation, the recurrence rate is high. We do now use some of these agents in what we call a neoadjuvant, meaning new or upfront way to sort of shock and awe the tumor and then go in surgically. There's not up there. We would love to get a randomized controlled trial on neoadjuvant use. It hasn't been done. And there's headwinds logistically in trying to execute such a clinical trial. But there is a discussion to be had with a patient on a case-by-case basis for giving them a period of drug, re-imaging, and then potentially going in as the Hail Mary to try and control the disease at a later date. So the role of surgery in general, so those are just sort of some case examples to get us on the same page of a typical journey. This is an arthroscopic setup. You can see the beauty of it. It's minimally invasive, whereas with the open approach, you have these big incisions. For nodular or localized TGCT, surgery is the mainstay of treatment. I think anyone who is, if you've got nodular TGCT and someone is recommending medical therapy, they didn't have her. I don't think that's a biased statement. I think most of my medical oncologists would agree with that. There's just some downsides to these drugs, cure rates super high with surgery. The risk of complication from the surgery is small. So it really is the treatment of choice for localized TGCT. Diffuse, obviously, as we're sort of revisiting all of these issues in different formats as we go through this. Debulking surgery is self-limiting. We know that 2/3 of patients are gonna, if not higher, are gonna have relapse. So we really don't like surgery. And now we are working with our medical oncologists to tailor medical and surgical interventions, as I've sort of alluded to. Good candidates for surgery are, again, symptomatic patients. So just because you have nodular TGCT doesn't mean you have to have it. Just because you have a mild form of diffuse type, which is pretty uncommon to have a diffuse type that's really minimally symptomatic. But if it is really minimally symptomatic, an argument, a well-made argument, just watch and see how it goes. And then again, the surgical options are arthroscopic, open, or a combined approach. And we'll have some examples of that. So when to operate, it's gotta be symptomatic. Okay, if it's not bothering you, it shouldn't bother the surgeon and it should just be watched. If it's progressive over time and it's usually progression correlates with symptoms, but not always, and in fact, Mrs. Jackie here. Hi, nice to see you. Thanks for sharing your story. We're gonna hear from Jackie a little bit later. Just because it's progressing, if your symptoms aren't and you know the diagnosis, doesn't necessarily mean you can have intervention. But the correlation with symptoms and progression are pretty tight, so usually it does mean that intervention is needed if it's progressive. Here's a graphic photo, sorry. Close your eyes, I meant to give you a warning. So this is a case where it was pretty nodular and we were able to pull it off the extensor tendon sheath. See it right there, and that's it. It's a nodular variant. You can still see because there is a little bit of brown there, which I then will electrocauterize. But if you take out all of the tendon sheath, the tendon is likely to rupture because you get rid of all the blood supply. So we'd rather take a small chance of a local recurrence than have a rupture. Because again, the endpoint here is function and quality of life. If I want to get rid of tumor, I say this time, euphemistically, we could just take the toe off, but that's worse than the problem itself. So we need to find that sweet spot where we're aggressive enough to try to address the symptoms and minimize the chance of recurrence. But we don't want to be overly aggressive. And at that time, I guess what's sad, I always get behind. So surgery, I'll move through this pretty quickly sometime. So localized TGCT, again, this is one we took out arthroscopically. It looks like a dumbbell shaped lesion. But this is exactly what it looks like under a scope. 90% curative rate, really small risk of local recurrence. I'd argue that 10 or 15% is probably high. We will use it in the knee, the ankle, the hip, and the shoulder. It's really advantageous, but again, if it's sitting right here or sitting, and you've got a case, I think a picture on the ankle where it's right there and a little incision, just pop it out. The recovery is probably as fast, if not faster, than doing a scope where you're sticking all these portals in and doing all these things and shaving it up. Open surgery can be used for localized as well. Here's a case of arthroscopic resection treated at an outside hospital. 42-year-old female, 8 years of knee pain, really gnawing pain in the knee. We worked her up. She got worked up, I should say, for patellofemoral arthritis, but her knee wasn't really. That's the kneecap not tracking well on the front, but her pain was always in the back. She was eventually seen by a sports doctor who went in, and this is in the back of the knee, and he said it appropriately said, it's pretty discreet. I think we can get that with a scope because he was pretty skilled with it. This is the pictures that demonstrate the mass. There's the lesion coming in with the scope, and was able to pluck it out. Because you have to put fluid into the knee and stretch things out, and if you're in the back of the knee where all the nerves are, it's like expansion onto the nerve. You can get some nerve irritability. So they did have some symptoms after from the removal, but fortunately it was determined that sports was bothering her. So the nerve eventually recovered, but there are some downsides, right? Even with fix it. 2 years later, no evidence of recurrence. So a win with the scope. This is a case in the hip, and you can see the disease here. I think it's highlighted. A 23-year-old woman with long-standing left hip pain, stiffness. Really, we did get a biopsy of it just to make sure, although it does look like classic tenosynovial giant cell tumor. This was taken out with a hip scope. I don't do hip scopes. We have some really, Dr. Freshman, we have a couple of people that do hip scopes and go in and get this out. And that's what it looks like, this brown stuff. This is it in the knee, and then this is it on the back table. And this is technology over reason in my view, but my foot and ankle surgeons love this. Do this. I just think just making incision, pop this thing out, put all these little scopes into a tiny little joint. I would just taken it out open, but my very skilled surgeons were determined to take it out this way. So, anyway. Here's a good, another gory one. Sorry, guys, close your eyes if you're, this is, was right there on the front of the knee. It was very easy to make an incision, and get it out. Recovery can be longer, but in this case, compared to sticking a scope in, this patient was back in sport at 6 weeks. 37-year-old female with palpable knee mass, noted after a bicycle accident. It was right there. We just, it was bothering her. We just popped it out with surgery. 14-year-old male with a 1-month history of knee pain. You can see it here, right on the front tibia, was coming off the joint. We removed that with surgery. Pretty straightforward, all surgical cures without problem. Here's one on the toe with, I got to him before my foot and ankle specialist got to him, they got the scope in there, and we were able to just pop it out. They recovered. Again, now those are all wins with localized. This is diffuse. We've already belabored the point. I'm going to move through this kind of quickly to keep us on time. These procedures, we took out the pictures because they were kind of graphic. We'll do big open approaches where we take down the blood vessels, just clean everything out. We as surgeons, in full disclosure, love the operations because they're cool, they're hard. You have to do some great dissection. You have a trainee who's really excited to see what's happening, but in the patient's best interest, we want to be very discretionary with that because again, it's like a shower and shake. Go in there, do some wonderful operation, but the time later, the tumor might be coming back. And now you got a scar. So here's an example of open surgery without the pictures. 33-year-old female with fogginess and swelling. She had they thought it was an infection. It was so diffuse that we did recommend CSF1 inhibitors, but she wanted surgery, so we did a combined approach. This is her MRI. You can see it in the front, all this disease, and then in the back, you've got all this other disease right here. So these are her incisions. This is a little graphic, but you can see this is what we did. We did what we call an arthrotomy. So here's her knee where we went in and removed the tumor. This is just post-operative swelling. And then this is in the back of the knee where we make this what we call lazy S incision, where because of the crease of the knee, you need to come across it somewhat in parallel. And we took that out there. She has, at this point, we did recommend, because we knew it was going to grow back, we put her on Pexy. She's had some improvement, but she's not really keen on the medication. So her journey is continuing. This is a case in the hip where you can see disease. This is the axial, again, that slice of bread where you can see the disease there. This is the coronal looking at it on front floss right there. This is a limited picture where we did an open, what we call hip dislocation to get the tumor out. So we're going to move this here. The arthroscopic surgeon thought the erosion of the bone was such that we would need to do it open. So after talking with the hip arthroscopist, we did this open. I'm going to skip through this because we are running over. Combined approaches. So this is something that you hear about because the front of the knee really is amenable to an arthroscope. The back of the knee, again, you usually have to go in open. This is a case of a 25-year-old with longstanding knee pain. They thought it was rheumatoid factor negative arthritis. They eventually got worked up for a synovial biopsy. Was consistent with TGCT. And we talked about all of the options. This was an old enough case that Pexy wasn't around, and so she got a combined approach. We went in the front, cleaned out. These are the images. Moving through this relatively quickly, I realized, but you can see the disease here. Actually, the cleaned out areas are here. So this is before where you see all this brownish, pinkish, whitish stuff, and this is after we've removed it arthroscopically. And then we go in the back. We went in the back. I took that picture out because it's pretty graphic. We got it back with a approach. Another case, 29-year-old with 6-month history of right knee pain and swelling. You can see the disease in the front of the knee. Again, this side view, you can see it there. And then she's got all this stuff in the back. She was really eager to have surgery and then to get it to bolt, but then would entertain medical management afterwards. So we did anterior scope, and then did the posterior approach open again. She did did well for 2 years, but had some symptoms of both the front and the back. She's on medical therapy now. We did talk to her about trying medical therapy up front. She was really bothered by it, so she wanted to try it. And her, paraphrase her, she was glad she kept this 2 years, but here she is again. This one's a little bit graphic. I missed this one out. Let's just skip that. I'll skip this too, because this is a good one to see as we wind down here. And we get time for Jackie. We go right into Jackie, right? Yeah. So this is just an important point to talk about arthroplasty, meaning joint replacement. You can see this is a MRI and X-ray picture of secondary involvement from the bony erosions, where we did need to take care of the disease surgically, but we also needed to replace the joint because the joint was so shot. It can erode, and that's why, again, we want to get that X-ray picture up front where we get a baseline of what the joint looks like. Because 5 and 10 years later on that journey, there might be erosions, and we want to know where the joints start. And then this patient had an open approach and treated with total hip replacement, and then is on medical therapy. And then I'll just finish up. This is a patient of mine who came in and says, my knee hurts. And his knee hurt in the joint line. Yeah, I noticed a little bit of fullness to the back of my knee. That's fine. Gosh, it hurts good. And he had some joint space narrowing, and he had knee arthritis, mild knee arthritis, but he could flex his knee, didn't hurt him here. So I went in and I did a total knee on him and left the posterior mass, and that's stayed stable, and says, yeah, I've got fullness in the back of my knee, but my knee feels great. So this is a nice way to illustrate that you gotta listen, the doctors need to listen to the patients. Primary chief complaints, we call it, knee arthritis. Did have TGCT at the top of your fossa, but it wasn't properly. So put him through the risk of putting scar in the back of his knee, and also do knee replacement or putting the dust with this placement. So going through both, for getting them all out, we could have had risk profile for this knee replacement much higher. So we've just left it. And now, if it does start to bother him, we can always go in later, get them last out. Or put them on medical therapy. This is just to show sometimes we have to do these things called manipulations. It looks kind of brutal, but then these patients will get stiff knees and when we operate on them with multiple times. So again, we as surgeons want to do less surgery rather than more, because the surgery in and of itself causes scarring and problems. So we really want to limit what we do interventionally from a surgical perspective. And then surveillance, we sort of touched on. I'm going to skip over this. We've talked about recurrences. And, you know, many patients, as you guys experience, are living with this. About half the patients continue to have symptoms even after surgical intervention. They don't necessarily like the medications. We don't have it all figured out, but I think it is fair to say that we're in a better place now with TGCT, certainly than we were 10 years ago, 20 years ago. But it is a journey that patients and families have to go through. So with this, Jackie, do you want to go through your own story? Or you want me to sort of tell it for you and then you embellish? It's nice to see you.
You too. Well, it's a special moment where Jackie actually sees Randall, so we thought that they could present it, you can see both.
Okay, you can present and I'll do.
Okay. So this amazing person, and make sure I get it right. In 2013, she was 28 and noted right shoulder swelling. She was worked up at an outside hospital when a biopsy she really wasn't bothering her so much at the time, but they did notice some bony erosions on the X-ray picture. She underwent a combined approach to the shoulder, which means both technologies, but unfortunately a year later had recurrence. She was relating stiffness and pain in the shoulder as well as numbness in the hands. She was surveilled for about 7 or 8 years, followed with progressive stiffness and obtained multiple opinions. In 2021, she was recommended for a repeat surgical intervention with a joint replacement. And then these are her images back from 2021. At that point, this is the MRI, and you can see this is the shoulder joint. We talked a lot about the lower extremity. The shoulder does get involved with it. This is a good way to think of this is like the shoulder joint on its side is like a golf tee with a golf ball on it. It's this little disc is the socket, and the golf ball is the head of the humerus. And this is it from the front on the coronal. I'm looking at it on FOSS. And you can see these erosions in the joint that are causing problems. So at that point, she was started on medical therapy and had improvement, but there was and there were symptoms, but there was progression over the course of a year. She decided to stop the medical therapy. She had bilateral carpal tunnels, and which is median nerve compression of the wrist joint. Her pain at that point, she reported to us, and she can elaborate, was not too bad, but she was really frustrated by her stiffness. And she saw some opinions up and down the coast, and beyond. She can elaborate. And we first engaged with her back in 2023, where we got an MRI. She did show progression. And you can see it here. So from 2022 to 2023, you can see the mass has grown. But in talking with her and listening to her, she was saying that it wasn't bothering her so much. And as someone, I love doing joint replacements. It's a lot of fun, but things wear out. She's a very young, dynamic person. And 10 years after a joint replacement, especially in the setting of TGCT, the loosening rates happen. So we want the long game in consideration. Yeah, there can be an early win, so with joint replacement, but TGCT might grow back even with medical therapy, and we have a loose joint 10, 15 years down the road that needs revision. What is your life look in those golden years as we get older? So we decided after much discussion to just watch it. She has had some progression. We didn't think that they were significant enough to go in and with the joint replacement again, because in her situation, the loosening rate for those implants is pretty high. And we have to think about what things look like a few years down the road. So she's been doing okay, not great, but okay. And we've kept the conversation going. And we just saw her as a patient virtually just a month or so ago after her most recent MRI, which does show some progression. So she is now going to share her thoughts with you.
Thank you, Dr. Randall. Thank you. Well, first of all, good morning. Good afternoon now. Good afternoon. Thank you. This is a privilege and honor to be here with you all. I don't have slides, so I'm going to refer to some of my notes on my phone here. So I just learned about the term TGCT. I was referring to it as PVNS all this time for 12 years. Because I was originally diagnosed with PVNS in 2013, and all my providers had called it that. I was unaware of the switch, the change to TGCT, until Dr. Stern informed me recently and enlightened me, and here I am today. I've had TGCT for 12 years, and time flies when you're having fun. So in 2013, I was diagnosed when a friend of mine saw a bump on my shoulder during a massage class at a health program here up in Weimar, actually an hour away from here. And I was among providers and doctors at the time, and they said, a radiologist said, you need to get an x-ray of that, just like you had plain x-ray, and then an MRI. And so once they saw that bump on my shoulder and saw what it could be, I needed a biopsy. And it seemed like after that point, everything went into hyperdrive mode, and there was a sense of urgency and a lot of pressure in 2013 for me to deal with this problem. So I did go ahead and do all of that. And within a 3-month span, I had surgery. It was fairly quickly done. And I Had a few imaging at that time that showed those finger-like villi and very few in the front and the back. But when the doctors, and I had a multidisciplinary approach, I had an open surgery resection in the front and arthroplasty in the back, arthroscopic surgery in the back. And the doctor said when I awoke from surgery that it was the size of a golf ball, which that is not what it appeared on the imaging. And they also had to do a bone graft at the time. So then, as many of you may know, being surgery survivors, you cannot drive for several months, and you must have someone take you to your PT appointments and doctor's appointments. And in this case, I was getting married in like 6 months. And speaking of that, my husband Ben is over there with my 2 children, Forrest and Noah, 9 and 6-year-old. So I went ahead and got married. And before I knew it, this was behind me, and surgery had taken care of the problem. And I was young and naive, and ignorance was bliss, because I thought, oh, you know, my PMS, excuse me, TGCT was gone, and I can move forward and live my happy married life. And as we know, there are more bigger, newer things to worry about raising a family now. So I was, for the most part, pretty asymptomatic. What I experienced post-op was stiffness and limited range of motion. I did continue with PT. I saw multiple chiropractors. I saw myofascial therapists. I saw active release technique therapists. I saw a slew of professionals who could help me with my joint, because my main concern was the stiffness in my shoulder. I didn't have so much pain. I did have tenderness and numbness down my arm, but for the most part, I kept myself pretty busy. And I think that just thinking positive and doing a lot of activities kept my mind off of the pain, and I was able to just move on. I had no choice to move on. At the time, the doctor who performed the surgery had gave me only one option, and that was surgery. And at that time, I didn't hear about any biologics. I did probably hear about a clinical trial going on, but there was just sense of urgency. So within 3 months, I went from 0 symptoms to now babying a shoulder. I was asymptomatic, and I just went for the surgery because that's what was recommended. Now we've learned that if you're gonna have surgery, make sure you're symptomatic. I did not have any symptoms whatsoever. So fast forward to today. In 2021, my family moved up to the Santa Cruz Mountains, where we're currently at now. And at that time, that was during the pandemic, we were very busy, and I was working as a respiratory therapist, my husband at a nurse. We were both at the front lines, and I was homeschooling my children. And that time, my doctor referred me to getting some medication on board and said, hey, we have this drug, this could help you shrink your tumors. I was being monitored every 6 months and getting those MRIs. And so I tried it, and I said, okay, I'm a good spot right now. We can go ahead and try this biologic. And I did. And I did that for a year. And after that year, I decided, great, it shrank my tumors, but I plateaued it. It no longer shrank it, but it maybe bought me some time. And I then had a few side effects that I thought outweighed the benefits for me personally and my body and my life at the time. And so I decided to not continue that after a year. After that point, the doctor then did recommend I go and see someone to perform surgery, and perhaps that would help. So I did see a number of specialists. I saw 4 down the coast of California, and I was in need of a first, second, third, and fourth opinion. And that's when I went looking online, and that's how I found Dr. Stern, Sydney Stern here. And she had referred me to a multidisciplinary team and said, you need to see this person. And I said, okay, let's go and make an appointment. And the first, second, and third opinion all said total shoulder replacement. That's what we need to do for you. And I said, no, this can't be. In my heart, I knew that for 10 years, I had not had major symptoms. And why surgery now? Was it deemed necessary? And what are my other options? So after that, I went ahead and came up to my fourth and final opinion, Dr. Lorr Randall. So we made the 3-hour drive to UC Davis, my family and I, all of us. And when I met Dr. Randall, this is what he told me without a doubt in his mind. He did it just like this, if you don't mind. He put his finger out at me and he said, don't let anybody touch your shoulder unless you're as old as I am. And if you're in misery and begging in pain. And that just blew my heart into tears. I was overjoyed that he had affirmed what I had felt in here, despite what other physicians had told me. And he highlighted that I was active mom. I had a whole life ahead of me. And once I had the surgery, my life would change. So yes, I was able to rear 2 children. Yes, I can work. Yes, I can homeschool. I can do all kinds of things and I live an active life. And here we are now. And he also gave me more knowledge on the surgery and possible revisions although that may be for someone else, it wasn't for me at the time. So what left the deepest impression was his compassion and his ability to sympathize with not only my disease, but with my quality of life and with my symptoms. He had understood. Go ahead, no worries. He had understood what I heard in my heart all this time, which was, you're doing just fine. Actually, you're doing great. At the end, Dr. Randall gave me a big hug. What doctor does that? And that 3-hour drive back home from UC Davis, from here, I ended up with an amazing physician and amazing team. And I cried happy tears all that day. So I'm here expressing that same joy and gratitude, having connected with Sydney and with Dr. Randall and all of you, and who continue to educate and inspire people like myself, and having inspired me to leave you with this take-home message. Take the time and take your time to invest in the right care team. I was being seen by sarcoma specialists, sports medicine, orthopedic surgeon, orthopedic oncologist, surgeon. And TGCT is as big as a problem as you make it or want it to be. I had 3 doctors tell me to go and get shoulder replacement, and then I land here. And you've seen my images. That is all they based their decision on. They didn't base it on how I was doing or how I was experiencing TGCT. It was all, wow, that looks like a very bad MRI. You need to have that taken care of via surgery. So there's truly no hurry. Life will still go on the same way until you're ready to take the next step. And just because an option is available doesn't mean you have to take it now or take it ever. I was feeling really, truly the pressure at the time in 2013 to just take care of it and do it. But now I've learned as I've matured and aged that my symptoms spoke louder than surgery. And that can change in the future as I explore other treatments and modalities. But after finding the right care team to empower me, now I'm confident in conveying this to my providers. And also confident in the care that I have now with the team that I have. So wherever I go and wherever TGCT takes us, I feel immensely blessed to help support. So thank you, Dr. Randall and Sydney, for this opportunity and for all of your help. And thank you all for allowing me to share my reflections on this and share this special space with you all. It's truly about the process and the journey. And may we all take the time in our lives, up and downs, to listen to that still small voice and say, you're doing just fine. In fact, you're doing great.